Good evening, everyone. I welcome you all for this Tuesday Masters Class program from Yashoda Group of Hospitals in association with IDCCM Hyderabad. As we all know, we are conducting this session since last 1.5 years, and it is really benefiting all the students who are aspiring students of critical care throughout India. Myself, Dr. K.C. Misra, and the HOD Critical Care at Yashoda Hospitals, Hyderabad. I'll be the course coordinator for today. As we know, today's topic is brain death and organ donation. It's one of the very, very important topic when it comes to any form of critical care examination, or maybe the things what we do on and off in our ICUs also. Everybody faces this kind of problem in their ICU, at least a few times in a month. And to moderate the session, we have two very senior intensivists and of our country. One of them we have heard during our student life. Till now, we are hearing, sir. Dr. Raj K Mani, who is the Director of Critical Care Services, Chairman, Pulmonology and Critical Care at Yashoda Hospitals, Ghaziabad, UP. I'll not be wrong if I will tell he's the godfather when it comes to end-of-life care in India. He is like forming like many guidelines and many more when it comes to end-of-life care. And which is, I think, one of the burning issues in India, which we need to have some proper guidelines based on which we can do. I think government should come out. I think sir is helping that. And our second moderator for today is Dr. Mohan Maharaj, who is the Director of Critical Care and Pain Services at Medicover Hospital, Visakhapatnam, Andhra Pradesh. He's a very senior examiner and intensivist when it comes to critical care. I welcome you both, sir. And thank you very much for accepting our invitation and taking out time from your busy schedule. The case will be presented by two of our DM residents from some hospital, Bhubaneswar, Odisha, Dr. Cherian Roy and Dr. Tapan Biswas. And I will request all the attendees who are attending the session to post their questions in the Q&A section. We'll try to answer those questions during the session or at the end of the session. And I request Dr. Cherian and Dr. Tapan to go ahead and present their case. I'll be in the backstage from now onwards. The session will be moderated by Dr. Raj Kumar sir and Dr. Mohan Maharaj. Thank you everyone for joining.
Shall I share my screen, sir?
Please go ahead.
Good evening, all. Good evening and respected teachers who are present over here. Myself, Dr. Cherian Roy, DM resident from IMS and Some Hospital, Bhubaneswar, Odisha. Along with me is my colleague, Dr. Tapan Biswas. He is also resident over there. So right now, I'm going to present today's case. So this is a 32-year-old gentleman who was brought to the emergency medical services after suffering a severe closed head injury resulting from a car versus pedestrian collision. So the patient was actually the pedestrian. On arrival to the emergency department, his Glasgow Coma scale was E1 V2 M2, 5 out of 15. Pupils were unequal and sluggish, reacting to light. And vitals, he was tachycardic with heart rate of 108 per minute, which was irregular. He was hypotensive with a BP of 90/60. He was bradypneic with a respiratory rate of 9 per minute. And he was afebrile with a temperature of 98.4 degrees Fahrenheit. And he was maintaining a room air saturation of 93%. On systemic examination.
Okay, Mani sir, just Dr. Roy, good morning. Good evening.
Good evening, sir.
Dr.
Yes.
R.K. Mani sir. So just want to ask in between some questions. It's okay with you?
Yes,
Absolutely.
sir.
Yeah.
Yeah.
That would be, we'll be interactive. Yeah.
Yeah. What is the definition of death, Dr. Roy?
Sir, death definition, actually the first definition was actually given by Uniform Determination of Death, which was formed in United States of America in 1981. According to them, the death is actually defined as an irreversible and permanent cessation of both cardiac and also pulmonary functions, or it will be the irreversible and permanent cessation of the brainstem functions. And that was actually defined as a brain death according to them. And they also defined at that time was that this determination of the death should be based upon the standard medical guidelines.
Actually, they said permanent cessation of all activity of the whole brain and the brainstem. Right. This is what the American UDDA said. Right. Actually, death, unified definition of death means ultimately the brain has no activity and it is permanently lost. And it can be in two ways. One is a circulatory cessation, right, which leads to loss of perfusion of the brain and the brain is gone, or a direct injury to the brain, which causes permanent cessation of brain activity. So that is what UDDA is. The definition in America differs from the definition in UK. In UK, for practical purposes, they have only talked about brainstem, loss of permanent cessation of all evidence of brainstem activity. Whereas in the US, it says entire brain and brainstem. So we seem to have adopted the UK definition. This is to nuance the definition because as we carry on, this becomes important.
Dr. Roy, what is the importance of temperature here? Just wanted to understand.
Sir, means any hypothermia, if it is there, then as we are actually moving on to the further discussions, whether that will be acting as a confounder or whether the temperature, what was the baseline temperature and how was the temperature varying as the time progressed. So that is the importance of temperature, whether he is normothermic or he is hypothermic, just to differentiate between them.
Absolutely. What is the importance of the blood pressure?
Blood pressure, sir, whether there was any hemodynamic instability was actually there at the time of presentation. And also definitely as per the hypotension is actually there, we have to resuscitate him according to the ABC, where the circulation stands for the correction of the circulatory disturbances. And always the first priority will be resuscitation of the patient, for which we want to know what is the heart rate, what is the blood pressure. And as per that, we will start the resuscitation with IV fluids or simultaneous vasopressors.
See, when do you get hypotension in trauma? It's in only the brain injury situation.
Sir, when there is actually brain injuries, when it depends upon the primary brain injuries, where nobody is actually witnessing what is actually happening at that particular point of time. So at that point where there is actually ongoing internal bleeding, like any ongoing bleeding from that of the brain, or because of the injuries to the other organs, like a hemothorax might have happened during that incident. So whenever there is an ongoing blood loss is actually there. So that will be actually reflecting, or we are actually visualizing any external big wounds or a pelvic hematomas or anything pelvic unstable pelvis, where there we are anticipating a huge blood loss, and hypotension can be a part of that huge blood loss also.
Very good. So you have to screen for injuries elsewhere and blood loss elsewhere, isn't it?
Yes,
so
sir.
That you mentioned here, there are no sign of any external injuries. Obviously, you have to do a focus scan.
Yeah, yes.
To find out if there's any other source of injury. And of course, you'll do all the other imaging, relevant imaging and clinical examination.
Yes, sir.
What is the duration of time when you get blood circulation is stopped and you get a pupillary reaction starts? How much duration it takes for the complete cessation of the blood circulation to the pupils and it stop reacting? How much time it takes?
Sir, I'm not sure about that, sir.
It is nearly 150 seconds.
Okay, sir.
Anyway, go ahead. Thank you.
Okay. So his airway was threatened. Breathing was, he was bradypnea with a respiratory rate of 9 per minute, and he was tachycardic and hypotensive. Cardiovascular system examination and respiratory system examination was within normal limits. Subdomen was soft and not distended. No external injuries or ongoing bleeding sites. and a focused abdominal sonography of trauma was done. It ruled out any form of pneumothorax, hemothorax, any collections in the hepatorenal pouch or splenorenal pouch, and also there was no pelvic collections. So
I'm sure if the BP is 90, you might have followed the rest protocol, right? In ultrasound?
Yeah, yes, sir.
Yeah, thank you.
So no comorbidities from the quick history which was taken in the emergency. In the personal history, we come to know that he used to smoke and consumes alcohol occasionally. But when was his last drink? That was not known. And he was not smelling alcohol during examination also. So we assumed that he was not under the influence of alcohol when this incident happened. So as a part of immediate resuscitation at the emergency department, patient was immediately intubated in view of the low GCS, 5 out of 15, and for airway protection. And he was started on mechanical ventilation. So hemodynamic support was initiated in view of tachycardia and hypotension, where he was resuscitated with IV fluids. Crystalloids was actually started. And once he presented, we noticed his unequal pupils. And also, since it was actually a road traffic accident, anticipated there will be a raised ICP. We rushed a bolus of 100 ml of 3% hypertonic saline as a method to reduce his ICP. Simultaneously, along with this thing, he was pushed for an urgent non-contrast CT brain. And along
is there any other clue that there is raised ICP in the, so far information given so far?
Bradypnea is actually there, sir. So
yes, and hypotension in the
yes,
absence of any other internal or external source of bleeding, because brain injury, bleeding into the brain alone is usually doesn't produce hypotension in the absence of raised ICP or coning, impending coning.
Yes, sir.
So, and you have the bradypnea to boot you. Now you are having pupillary, signs emerging.
Yes, sir.
That's right. So you acted quickly in giving 3% hypertonic saline and asked for a surgical consult. Good.
Yes. So immediately the non-contrast CT brain was actually done. And as we can see in this NCCT brain, this is a non-contrast CT brain, which is actually showing a large frontotemporoparital subdural hematoma, which is actually causing a midline shift. And it is actually causing ipsilateral effacement of the ventricles. And also there is loss of the gray white matter differentiation. So from this CT, it is clear that there is a large subdural hematoma, which is causing its mass effect. And also due to loss of Sulci-Guérin differentiation, there is a feature of elevated ICP is also there. So
Dr. Roy?
Yes, sir.
You have center of CT scan, so you have done it. The center does not have a CT scan, that number one. Number two, if the MRI and CT scan both differences in this situation. Thank you.
Yes, sir. So next plan of management.
I want you to answer these questions, because just want to ask you, if you don't have a CT scan in your center, what you do and how you are going to do. And second thing is that you told that you are intubated with everything, because most of the times in the neuro cases, CPP is more important rather than the ICP. So how you intubate them? Because in emergency department, actually what I feel is most of the times in the night time or daytime, I don't disrespect emergency department. The lowest people or the junior most people, post-MBBS people are there at the time of intubation who are interested to intubate. And the highest degree, highest qualified, highest skilled people will get people in the hospital. But by the time you go there, they intubate. So that makes a lot of difference in the outcomes of the patients of neuro cases. Because whether they become brain death or become vegetative, all these things matters depends on the intubation criteria they are using, how safely they are intubating without changing the ICP and the CPP.
Yes, sir. So basically, if the center is not having any CT, if there is a provision of a bedside ultrasonography, I would go along with doing a bedside optical nerve sheath diameter. And if the diameter of the optic nerve sheath is more than that of 5 millimeter, it is closely suggestive of feature of raised ICP. And considering this patient whose already GCS is actually 5 out of 15, my first priority during intubation is that I should blunt all the hemodynamic responses that could happen. And because if I allow those hemodynamic responses to happen, that will be counterproductive by increasing the ICP further. So first of all, as a part of intubation, I will start with the pre-oxygenating the patient with 100% of oxygen for 3 minutes. After that, I will cue the sedative agent, which will be, I will be preferring injection nalbuphine or injection fentanyl, which may be available as per the hospital policies. Then my induction agent will be a cardiostable agent in this case, because the BP is actually on borderline, while all ongoing simultaneous fluid resuscitation is actually there. So I will induce with the injection etomidate 0.2 to 0.6 mg per kg according to the weight. And along with that, I will rush the fluid boluses and also will keep injection norepinephrine as a supportive agent in order to keep a backup in case if there is any hemodynamic instability is actually ongoing. After that, I will prefer for the rapid sequence intubation because this patient came as an emergency case, as I don't know when he was actually taking his last feed, whether his tummy was actually full. So I will go for rapid sequence intubation. So after ensuring complete cessation of his respiratory efforts and a patient is fully sedated, paralyzed, and also passive, I will proceed with that of a direct laryngoscopy, will visualize vocal cords under direct visualization, will intubate with an 8 or 8.5 number tube since it is a male patient, and then we'll start mechanical ventilation. And I will keep on monitoring his vitals at the same time with keeping the time intervals of the monitoring, like especially BP monitoring, usually NIBP monitoring. I will keep it between a time interval of at least 2 minutes or 3 minutes so that I can have quick readings, whether he is actually going for any hemodynamic further instability, and I can manage accordingly.
Very nicely explained. The only point I would like to say that do not give as per kg body weight and boluses. Just give intermittent and check for the responses regularly. That's all. Thank you. Go
yes,
ahead.
Thank you. So as a next plan of management, after evaluating the patient and interpretation of the non-contrast CT, patient was immediately shifted for emergency frontotemporoparatal decompressive hemicranectomy, because in the CT room, when we discussed, the radiologist told there was a midline shift of 7 millimeter. So patient was immediately transferred to OT, and intra of patient was transfused with 1 pint of PRBC. Otherwise, there was no any major events that happened intraoperatively. So the surgery was done, a decompressive hemicranectomy was performed, and post-surgery, patient was actually shifted to the ICU for further management. So in the post-op course in the intensive care unit, patient was continued on invasive mechanical ventilation with emphasis on providing the cerebroprotective measures. Soon after admission to the ICU, the patient's attenders were called, and the neurosurgeon and the intensivist, both of us sat together, described about the details of the patient's injuries, current condition, the surgery which has been done, and what is the anticipated outcome. All these things were explained in details to the attenders. So on further evaluation, the GCS was E1, VT, and also M2. Again, a bedside optic nerve diameter was actually done. So that was also found to be elevated with 5.6. And therefore, the raised ICP management in the form of 3% NS was continued in order to target a serum sodium of 150 to 155 milliequivalents per liter. So soon after the admission, the ABG was done, which was showing pH of 7.31 with a PO2 of 96 millimeters of mercury, PCO2 of 49, bicarbonate of 22, glucose was 142 milligram per deciliter with a base excess of -1. So this was suggestive of acute respiratory acidosis, which was PCO2 was 49 and pH was 7.31. So as cerebroprotective measures, I changed the ventilatory settings in order to target a PCO2 between 30 to 35 also. So day 2 was uneventful, and day 3 in ICU, during routine rounds, the Glasgow Coma Scale was again assessed after stopping the ongoing sedation. The GCS was found to be even VT M1, and immediately the patient was found to have a heart rate of 51 per minute, and BP was 170 by 110 millimeters of mercury. So impending herniation was suspected. So immediately patient was rushed for an immediate repeat CT, again by simultaneously giving one bolus of 3% NS. And the CT now showed expansion of the hematoma with a transtentorial and also subfalcine herniation. So this is the repeat CT.
Every time you're giving, Dr. Roy, every time you're giving 3% saline, what do you check in between? As you said, rightly maintain the sodium levels of 155, right?
Yes, sir. Yes. Serum sodium monitoring twice daily is the usual protocol that we follow in our ICU, sir, while the patient is actually on 3% sodium. And if the target is actually achieved, we will titrate the 3% sodium infusion rate and gradually we will stop it.
Do your ABG machine having a electrolyte reports along with ABG?
Then we will go rely with the, we usually rely with the central laboratory values, sir. Okay, so in the morning and also night, we will fix a particular time for sending electrolytes. And as per the central laboratory values, we will target the sodiums.
Okay.
So this is the repeat CT which was done on day 3. So as in the picture, you can see there is a large defect or bony defect, which is a status post left frontotemporoparatal craniectomy with expansion of the brain tissues. And there is actually the hematoma, the acute white things that is actually causing again increased ICP features and effacement of the ipsilateral ventricles. And as per the CT report, there was a transtentorial and also subfalcine herniation. So this was the laboratory investigations as the patient was actually admitted for the first 3 days, day 1, day 2, and day 3. There was a slight drop in hemoglobin from 10.8 to 9.4, but this was with not crossing the transfusion trigger. Total counts was actually within the normal limits, 11,600. Platelet count was also within normal limit. In urea creatinine, we noticed by day 3, there was a slight increase in the serum creatinine was actually there. And the serum sodium by 3rd day, it has already become 157 and potassium was 4.2. So on day 3, when we evaluated the charts, the patient was actually having 250 ml of urine output per hour for the last 4 hours. And there was also the sodium was actually 157. So we presumed the patient could have a possibility of diabetes insipidus. So with all these things, as the GCS was...
What is the mechanism of diabetes insipidus, Dr. Roy?
So, sir, diabetes insipidus is an endocrine abnormality. So here we have mainly 2 types of diabetes insipidus. One is central diabetes insipidus and nephrogenic diabetes insipidus. This is mainly due to the vasopressin, which is actually being produced and released from that of the posterior pituitary. So what happens is that in central diabetes insipidus, we are having a loss or complete absence of the production of a vasopressin from the posterior pituitary. And what happens in nephrogenic diabetes insipidus is that the body circulation is having the vasopressin, but there is no response to the vasopressin. So how it is clinically diagnosed is that there are certain criteria. One is the urine output, which is considered to be more than 400 to 500 ml per hour for the last 4 hours. Serum osmolarity of more than that of 300 milliosmoles per kg. Serum sodium of more than 155 milliequivalents per liter. Urine osmolarity will be less than that of 280 milliosmoles per kg. So if all these criteria are actually satisfying, we will suspect a case of a diabetes insipidus. Now, the next step to follow up is whether it is a central diabetes insipidus or a nephrogenic diabetes insipidus. So for that, we have a test that is actually this vasopressin response test. So in vasopressin response test, what we usually do is that we will give a bolus dose of 0.5 units per kg of vasopressin, and we will see for the urine osmolarity. If the urine osmolarity is increasing by more than that of 50% from that of the baseline, then it indicates that it is a central diabetes insipidus, where there is actually deficiency of the production or release of the vasopressin from that of the posterior pituitary. If there is no response, or it is actually less than that of 50, then it comes to nephrogenic diabetes insipidus.
Good, Cherian.
Thank you. So, as the patient's clinical condition was on the deteriorating trend, a detailed clinical examination was performed, and we found that there was no purposeful movements to that of noxious stimuli, and pupils were bilaterally dilated and fixed. The plantars were mute, Doll's eye reflex was absent, cuff reflex was absent, and there was no spontaneous respirations were there. So as part of the further steps, the patient's attendees were again called for detailing the current condition, and a second round of counseling was done, which included the anticipated outcomes at that particular point of time, and also what is the further plan of our care. So involvement of multiple specialists to take a combined decision was taken, and the need of subsequent counselings were actually taken into consideration. So all brainstem reflexes tests were absent at that time. So we decided to go ahead with that of the apnea test.
What are the criteria to diagnose brain death? What are the prerequisites? Let's start with prerequisites.
So, sir, prerequisites includes, first thing is that patient should have a core body temperature of more than 36.5 degrees Celsius. Second thing is that patient should not have any hemodynamic instability, that is a systolic blood pressure of more than or equal to 100 millimeters of mercury. There should not be any electrolytic abnormalities, especially the serum sodium should be within normal limit, and also serum calcium should be less than that of 12 milligram per deciliter. And if we are suspecting, initially we suspect any kind of this intoxication, especially alcohol and all. So urine blood alcohol level should be less than that of 80 milligram per liter. And also we should completely rule out any kind of confounders that could explain the possible reversibility of coma. That means patient should not be under any particular sedation. He should not be under any effect of paralytics. Even if we have stopped the sedation or the paralytics, at least we should wait for minimum 5 T-halves of that particular drug to get its complete elimination. So if all these prerequisites...
In the first prerequisite is you have a catastrophic brain injury which can explain, and the radio imaging which can explain the possible brain death.
Yes.
So that you have amply clear. So yes. You have other confounders you have explained. And then lastly, the elimination of sedation and paralysis. Now, has that T-half been covered when you talk to the family?
Yes, sir. Almost we waited for 8 to 10 hours we waited after stopping. Means the sedation was actually stopped early in the morning, and the events are actually being explained by evening. So by that time, we expect, before explaining the conditions also, we reassess the patient, and there was no change in the clinical examination findings, what we found in the morning also. So at that time, we called the attenders and started explaining to them.
So how was the apnea test performed?
So, sir,
by whom?
So apnea test, first apnea test was actually performed by the attending intensivist, sir, at that point of time in the ICU. So for apnea test also, there was, we assessed all the prerequisites are actually being fulfilled. So the core body temperature of more than 36.5 degree, the systolic BP of more than that of 100 millimeters of mercury. There was a normal...
No, you mean to say you performed apnea test twice?
This is the first apnea test which was actually performed, sir.
No, that's what is the issue. Our 2014 guidelines of TOA, it says you need to do only this. only once, the second time. And then did you have a brain death committee in your hospital? And who oversaw the apnea test? These are the TOA, Transplantation of Human Organ Acts.
Yes, sir. Yes.
Act requirements. So do you have a brain death committee in your hospital?
No, sir, we don't have.
Yeah, so there are certain formalities.
Yes.
So all tests other than apnea test you've done, because the criteria for brain death is clinical or clinical plus ancillary tests. What is your opinion?
Sir, if we are not able to, clinical is only recommended and ancillary.
Yes. Clinical is the only recommendation. So under what circumstances you will ask for ancillary tests?
Suppose if we are actually not able to perform any clinical test, or if the results of the clinical test what we performed is inconclusive, then only we can consider ancillary test as a surrogative method to support the diagnosis of brain death. Or
apnea test needs to be aborted for some reason.
Yes.
Isn't it? It aggravates instability. It dips the BP very fast, or it dips the oxygen, SpO2 very fast. Isn't it?
Sir.
There's instability, then you will think of what are the ancillary tests you will consider?
Sir, ancillary test we will perform first of all in order to confirm the brain death. And we can classify the ancillary tests into two types. One set of ancillary test will test the complete cessation of the cerebral blood flow. And the other set of ancillary test will test there is an absence of the bioelectrical activity of the brain. So if we are actually going with the cessation of the cerebral blood flow, we can have cerebral and conventional cerebral angiography or conventional cerebral scintigraphy. So if in between them, if we consider conventional cerebral scintigraphy, it will give us an idea about both the cerebral blood flow and also the cerebral metabolism, while the cerebral conventional angiography will give just as an idea about the cerebral blood flow. How to interpret is that in cerebral angiography, there will be complete absence of the flow either at the bifurcation of the carotid or at the level of circle of Willis. That is a conventional cerebral angiography. But the problem with conventional cerebral angiography is, one is that patient needs to be transported, which is not possible if the patient is hemodynamically unstable. Second thing is it is an invasive procedure. Third thing is that the dye which we are actually injecting can cause nephrotoxicity if it is actually a renal patient or something like that. And in conventional cerebral angiography, all the 4 vessels needs to be visualized also if we are actually injecting the dye. Another method to test this is actually the transcranial Doppler. So this transcranial Doppler is actually a screening tool which we can do at the bedside also. Here, what we are actually doing is we will use the ultrasound probe in order to see the blood flow of the major blood vessels, either the middle cerebral artery, internal carotid artery, or any of the other major blood vessels. But what we are usually anticipating here is actually there will be absence of the diastolic blood flow and also the systolic peaks which are actually happening, early systolic peaks. But the problem with that of the transcranial Doppler is that it is highly subjective because it varies from the operator. Second thing is that if the patient is actually undergone EVD and ventricular displacement, brain placement, or a temporal craniectomy, then that window, we need actually temporal window to do this thing. And the third thing is that the posterior circulation is actually getting difficult to visualize with that of the transcranial Doppler also. But one advantage is that if we are actually doing transcranial Doppler and if we get an idea about there is flow is actually present, then we don't need to jump to that of the conventional angiography as an ancillary test, because we are now sure that at least we cannot label once if it is blood flow is actually there, we cannot label it as brain death. So that is about transcranial Doppler. Third one is a radionuclide imaging is actually there. That is by using HMPOA, technetium isotope. Here what is actually being seen is that it is, we will give it the technetium isotope and how much amount of uptake is actually there by the cerebral tissues is actually there. That is the technetium radionuclide imaging studies. But the pitfalls here is that if the patient is actually under barbiturates or if the patient is having hypothermia, that can interfere with that of the technetium uptake test also. Fourth test that we usually perform is an electroencephalogram. Electroencephalogram, as we all know, that it has good value, but if there is no activity within that of 30 minutes of recording, then we can tell that the patient is actually having no brain activity. But again, here, hypothermia is one of the pitfall. Then the ICU infarcts can interfere with that of the this thing. And the surface electrodes, it will pick up only the surface activity, not exactly what happens deep inside the brain will not be a proper value for this EEG. Then another test that we can use is the somatosensory evoked potentials. So somatosensory evoked potentials by bilateral median nerve stimulation, if there is no response, then we can consider it as an ancillary test. But the problem here is that soon after a cardiac arrest patient, if we do the somatosensory evoked potential, it can produce a false negative result also. And finally, we have the CT angiography and also the MR angiography. But the problem is that these are not validated as of now. The reason being that in MR angiography or CT angiography, even a slow flow of the blood may be interpreted as a complete absence of the blood flow also. So these are some of the ancillary tests that we can consider for performing brainstem death.
That's an excellent exposition of the ancillary tests. Yeah. Now you can proceed. Okay.
So after the first apnea test, the result of the apnea test was explained to the patient.
See, I must say that for the apnea test, you need to take consent from the family according to our present POA rules, right?
Okay.
So you can't just do the test and then inform the family. See,
Okay.
Everything else being pointing towards brain death, you talk to the family about the strong possibility of brain death. Then 6 hours apart, then you do the second test, and then you do the apnea test in the presence of the brain death committee, right? Which consists of 4 physicians.
Yes.
Right. So these rules have to be followed, and the forms have to be accordingly filled. And similarly, the apnea test has a certain protocol. Can you describe the protocol?
Yes, sir. So apnea test, first of all, we have to find out all the prerequisites has been completely satisfied. That means a core body temperature of more than 36.5 degree. And there is
We don't have to go through that again. Just describe only the apnea test now. Yeah.
Yes. So after satisfying all the prerequisites, the first step is actually pre-oxygenating the patient with 100% of FiO2 for at least 10 to that of 15 minutes. And also we have to target a PCO2, that partial pressure of carbon dioxide, between 40 to that of 45. So the rationale behind doing this apnea test is by allowing the hypercarbia and also enough acidosis so that to stimulate the medullary respiratory centers. So after that, we will disconnect the ventilator. We will connect the oxygen via a catheter, and this catheter can be a Riles tube or a suction catheter, which is connected to the wall mount oxygen device, and the size of the suction catheter should be less than 70% of the internal diameter of the endotracheal tube. Otherwise, it can confound the results by causing CO2 retention. So the catheter should be placed at the level of carina, and it should be actually kept for at least 8 minutes. So after 8 minutes, what we assume is that hypercarbia usually increases the carbon dioxide by 2 to 3 millimeters of mercury by 10 per minute. So during this thing, we are observing for that of the respiratory movements. So here the respiration will be defined as any form of chest excursion or the abdominal excursion. And after that, we will look for the, we will reconnect the ventilator, and then we will look for the repeat arterial blood gas analysis. So if apnea test is actually said to be positive, if there is no respiratory effort from the patient, plus the partial pressure of the carbon dioxide is more than or equal to 60 millimeters of mercury, or it is actually more than 20 millimeters of mercury from that of the baseline is.
Actually, for adults, it is more than 55.
Yes.
For children, it is 60 or more. And
yes.
So this is by our TOA criteria, or Indian criteria. It may differ from country to country, but this is our country criteria.
Okay.
Dr. Cherian?
TOTA is a Transplantation of Human Organ and Tissues Act. Yeah. 1994.
Yeah,
so TOTA or TOA this is a very important act. We must all remember. And we must go by the protocols recommended in that act.
Recently,
because there is a legal component to all this determination.
RK Mani, sir. Recently, Odisha had made this act, and recently they have a separate, like, in Andhra Pradesh, we have a Jeevan Dan, and like that, they have a separate, they have been formed. Am I right, Dr. Cherian?
Yes, sir. Yes.
Actually, sir, the act was done by central government and asked to each state to pass separate legislative law in their own state. And according to that state, the time or parameter may be slightly varied.
Yes, Kerala has its own rules. Tamil Nadu has its own rules. We'll come to that, but I just wanted to tell you the act, what the act is telling, and then your own state's laws should also, you should familiarize yourself.
Transplant of Human Act 1994 and some multiple amendment, last amendment 2011 and 2014.
14, yeah. 2014 is the last amendment.
Yes.
Okay, proceed now.
So since both apnea tests tend to be positive, the attending physician saw the patient and pronounced him brain dead. So a referral to the local organ procurement organization was done because the patient's physical examination and 2 positive simultaneous apnea tests were consistent with the brain death.
One small request, Dr. Cherian. Go to the previous slide. You said the possibility of organ donation and explain to the close relatives. So here the comes actually, who is the close relative who's supposed to be given consent? His mother, father, brother, sister, spouse, who's going to be legally?
Next to kin is the legal part of to consent organ donation. Next to kin.
No, next to kin means.
Next of kin means what? That is also defined in the Act.
That is important. That is important.
Very important.
Sir, 1994 TOA Act also defined as the first degree relative. That means either father, mother, son, daughter, and also
first is spouse.
Yes, sir.
Spouse comes first.
This is what I want to speak upon.
Then father, mothers, children, siblings. Then in the amendments, 2 others were added.
Yes,
grandparents and grandchildren.
Yes, sir.
Yes.
Okay,
and
they were added in the
and also swipe donor. And last amendment also adds swipe donor.
I see. Okay.
What did you say? Last amendment also?
Swipe with the donor.
Swipe.
Patient party can exchange.
Swap donor.
Organ.
Swap donor.
Swap donor.
Right, that's very interesting. These rules, legal aspects are extremely important when it comes to brain death.
Yes,
we should be well up on that.
Transplant, very, very important. So in case of wife is absent, wife is not there, what do you do?
Next in the hierarchy, and the family member who was brought the patient.
Actually, now it's not easy. There's some NHRM, some cases are going on by somebody, because it's important saying that even if the person is not there, you should supposed to take the consent from the person by phone, then only others person, because non-availability, then only you can take the consent from others. That's what they say.
Yeah. Phone is another way, but if absolutely no, you can't have any access, then the next available, in that hierarchy of surrogates that's mentioned.
Yes, sir.
So the consent, as per the questions written there, the consent has to be first, it comes to the spouse and then the next kin, and after taking consent from the spouse, if they're there or not, they're legally they are more important. And not married, below 18 years, it's a parents.
Yes.
So in India, we have the opt-in system or opt-out system of.
Sir, we have only opt-in system. Opt-in system.
Yes, we have the opt-in. So it is our duty as a physician to ask if the patient had informally or formally expressed to the family any desire for donation.
Yes.
Very important.
Sir, I think it is not a duty of a physician because there is a conflict of interest. It should be done by third person, especially
absolutely.
The
I mean, duty
authority.
of the duty of the coordinator.
Yes, sir.
Yeah, actually, he's quite right. Tapan is quite right. First approach should be with the coordinator. Why? Because otherwise you will be suspected of your intentions. So that is why the approach to the family about transplantation should be de-linked from the diagnosis of brain death by the treating team and those involved
It will never happen that because we are in the same hospital, it's going to be there. But at the end of the day, the legal responsibility goes to the surgeon and the physician, the director of the hospital. These are three people who are going to be held responsible for the legally. And as Dr. Satish asked me a question saying in the group that can we involve the judiciary?
There is no need for judiciary involvement, but there is a government involvement is very important. In the medical board, which is formed by 4 members, one of the member will be from the government representative.
No, we don't need to involve the judiciary.
Yes, sir. Judiciary.
Unless there is a unless there is a dispute of some sort later on. See, ongoing. This is a clinical. It involves only the treating physicians and the brain death committee and the transplant coordinator when you're initiating the conversation.
Yes, sir. One of the member of the brain death committee will be government authorized.
No, they are all government authorized. They have to be impaneled by the competent authority.
Right?
Also called AA. The AA has to authorize.
Yes,
firstly, it has to authorize the institution to have retrieval, transplantation, and impanel a brain death committee.
Yes, sir.
All these are authorized physicians.
By government.
Yeah. By the competent authority. Which is set up by the government.
Committee and external committee.
No, it need not be external committee. The brain death committee is in-house committee, but it is empaneled by the AA. As a medical administrator, I've done that in all the hospitals I worked in. You got to send names of the physicians and which are then recognized and empaneled. And those are the people who form the brain death committee. So that is what it says RMP, who is in charge of the hospital. So it's a medical director or somebody or medical superintendent. Then an independent RMP. Then the neurosurgeon or neurologist. And then the treating physician. If you don't have the neurosurgeon, neurologist, the amendment says any surgeon, physician, intensivist, or anesthetist who is empaneled by the AA can be part of the committee. Okay, this is to clarify the rules.
Yes,
latest rules.
Yes, sir.
Go ahead.
So according to the latest rules, you don't have to do 2 apnea tests. Only one apnea test. Yeah, one apnea test. That is the second. That's the last test you would do. See, apnea test is a risky proposition. You can't do it twice. There's no need to do that. And that also needs consent.
Yes, sir.
And in our country, unfortunately, it's a very unfortunate thing. In many countries, it's not required. But in our country, this requirement is there. That firstly, you're going to be a recognized center by the AA. Secondly, you've got to get consent from the next of kin.
Relatives.
Yeah. So you do the first set of tests and all those prerequisites, everything you follow. And then you approach the family, take the consent for confirmation after 6 hours with an apnea test. Then it should be done in the presence of the brain death committee. One member does the test and the others witness the test and sign. That is the way the formalities are completed.
and time of the death will be the first 6 hours apart, the first at a time.
I know that's a controversy where that's not been settled, unfortunately. Timing of death has not been settled in our law. It's a very crucial point. I agree.
Yes.
Can you just explain time? I mean, opt-in, opt-out.
Sir,
who will explain opt-in, opt-out? Yeah.
Yeah. So all the donation of the organs are voluntary systems, and these voluntary systems can be of two types. That is opt-in system and opt-out system. Opt-in system that the donor has already given the consent that he wants to donate his organ. But opt-out system means those who doesn't have given the consent are also considered as potential donors. So that means it is not still practiced in our, it is not applicable for our country, but in many Western countries, this opt-out system, those who haven't given consent are also considered as a potential donors actually.
Actually, in Spain, when you apply for a license, driving license, you are given the choice to opt in or opt out. I mean, to opt for a donation or not. Okay. Yes. So everybody has to fill that choice.
Yes. This is one of the patient's autonomy.
Yes. So the autonomy is honored if the patient has opted in for donation, and nobody can question that, not even the next of kin.
Yes, sir.
Right. So that has to be honored. That altruistic wish has to be honored.
But the consent, the will should be registered by government authority during a life.
I know that is right, but then our rules also say that whether it is formal or informal wish expressed to the family should be elicited. Yes. And perhaps that's what the coordinator should do.
Right.
The transplant coordinator should ask, has the patient ever expressed any desire to donate? And if so, we would like to honor it. So that is the way you put it.
Right, sir.
Yes, sir.
Okay, Cherian, can you proceed?
Yes, sir. So an organ recovery coordinator arrived and he evaluated the patient and determined that the patient was a suitable candidate for organ donation. So meanwhile, during this close monitoring of the patient, we noticed the patient had a transient hypotension, which didn't respond to fluid boluses, and therefore injection norepinephrine at a dose of 5 microgram per kg per minute and was started and was continued as a maintenance infusion. So finally, the patient's family was informed regarding the patient's death. And furthermore, attendees were informed about the option of organ donation. So initially, they were not in a state in order to accept for the thing. Therefore, the OPO staff member who is trained in grief counseling and requesting organ donation, as well as a treating physician, spoke with the family and described in details regarding what is meant by organ donation and the possibility that the deceased person is actually going to be alive through another person's life. So all those things were actually explained to them. And after a long decision, the family agreed to donate organs, following which the steps in order to manage a potentially brain dead organ donor was initiated by our team. So steps to tackle the brain death specific intensive care issues were initiated there onwards. So first priority was actually to overcome what all physiological and pathophysiological consequences that the brain death can cause towards the entire human body. In order to tackle all those issues, we started the measures. So it included, we started optimizing the BP and also the intravascular volume to keep the patient euvolemic and hemodynamically stable. So patient was on IV fluids and also vasopressors with the target map in order to maintain adequate perfusion. So even though the patient was started on minimal norepinephrine previously, it was simultaneously stopped subsequently as the BP was actually maintaining without any vasopressor support. And the lung
sometimes the BP is high, sometimes because of the adrenergic storm that happens after coning.
Yeah, yes.
There is a high BP and there is, the capillary leak syndrome.
Yeah.
Now, and that also damages the retrievable organs.
Yeah, yes.
So what do you do in that case?
So actually, sir, there is a concept of the sequence of rostral to caudal ischemia events are actually there. So what happens in the first stage is that there will be extreme amount of autonomic storm. So in such cases, what happens is that it is the vagal, which is actually not the sympathetic overstimulation will be there, and there will be hypertension. So in such cases, extreme short-acting beta blockers like esmolol or even sodium nitroprusside we can use to control the.
Absolutely. Well done. Yes, that should be remembered very well.
Yes, sir. So after that, optimization of lung functions and also ventilator parameters with the main strategy of lung protective ventilation. Why we took this lung protective ventilatory strategy is that oxygenation is very important to keep all other organs vital. So what we targeted is to keep the tidal volume of 6 to 8 ml per kilogram. Also, we wanted to keep the saturation of more than 95%.
No, lung protection strategy is also extremely important for retrievable lungs.
Lung, yes, especially lung.
Because it's very difficult. Only a small proportion of lungs are, good quality. So we are not should be thinking only of other organs. Increasingly, in our own country, we are able to do lung transplantation, particularly in the south. But now even in the north, it's catching up a lot. Yeah, particularly in Mohan Maharaj Ilaka. Yeah. So we have to be sensitive to the lung quality, right? So if you all the lung protective strategies are for this purpose as well.
Yes, sir. So because we want to target the saturation of more than 95% with the least FiO2. One more reason being is that since there is an autonomic storm that is actually happening, there is a possibility of a huge cytokine release and also free oxygen radical injury is also there. So giving extra amount of FiO2 or a very high FiO2 is again counterproductive also. And optimal PEEP. Adequate in order to keep the oxygenation, and also the other strategies in lung protective ventilation like the plateau pressures of less than 30 centimeters of water, and also simultaneously providing a good oral hygiene and also pulmonary toileting, because the patient is in ICU, day 3 of ICU stay. So possibilities of hospital-acquired infection either in the form of a ventilator-associated pneumonia. So all those things were actually taken into consideration. Simultaneously, we also kept a look on the correction of acid-base disorders while serial monitoring and optimization of the electrolytic imbalances, and adequate glycemic control was also achieved. And the patient in our case had a diabetes insipidus, which was managed with that of IV fluids and also desmopressin. And maintenance of normothermia was also taken as a priority. And for that, the warmer was actually...
Roy.
Yes, sir.
Just before that, you have given all the reflexes where R K Mani told and all the reflexes. Can you just see the names of sensory or ascending or descending? What is the pattern of the nerves for the reflexes?
Yeah. Yes, sir. So
for the students to know that.
Mainly 6 brainstem reflexes that we are actually testing. Starting from the first one is the pupillary light reflex. So the pupillary light reflex is mainly assessing the cranial nerve number 2. So the afferent is actually cranial nerve number 2 and the efferent is actually cranial nerve number 3. So that is actually assessing the function of the midbrain. That is about the pupillary light reflex. So 2 things we are actually seeing here. One is the pupillary size and second one is the reflection towards the light. So one size can be either mid-dilated, that can be 4 to that of 9 millimeters, or it could be fully dilated also. That is regarding the size of the pupil. Second thing is pupillary light reflex. One important point to be noted is that the pupillary light reflex will be intact only if we have a brainstem intact. That means if it is absent, that means that the brainstem function is actually not there. So in the first thing, that is the pupillary light reflex, it is a cranial nerve number 2, that is the optic nerve which is actually being tested, and the afferent is 2 and efferent is oculomotor nerve, that is a cranial nerve number 3. Second test is actually the corneal reflex. So corneal reflex here, what we are actually testing is a pontine function. So here, what we are actually testing is 2 particular nerves. One is a trigeminal nerve, that is a 5th, and also the 7th, that is the facial nerve. So here, what we are actually doing is that in the conjunctiva, we will actually touch with that of a cotton bounded cotton swab, or it should be a cotton bounded stick only. And we should take extreme care is that we are not touching towards the extreme lateral aspect of the conjunctiva, because that is too insensitive to produce a reflex also. So what we are actually seeing is actually the blinking of the eyes. And here what we are actually testing is cranial nerve number 5 and cranial nerve number 7. So the afferent is a 5th nerve, that is the trigeminal nerve, and efferent is actually the 7th nerve, that is a cranial nerve number 7. So that is actually regarding the corneal reflex. Third one is actually the gag reflex and also the cuff reflex. So here both the afferent nerves are actually 9th nerve, that is the glossopharyngeal nerves, and also the vagus, that is the 10th nerve, is actually being tested also. So for the gag reflex, what we usually do is that usually we take the tongue depressor or a spatula and touch the posterior pharynx also. So look for the gag reflex. And in cuff reflex, definitely the patient is actually intubated. So just put the endotracheal suction catheter through the endotracheal tube and look for any cuff or bucking reflex that is actually present by the patient. So that is the cuff and also gag reflex. So both these are again checking the medullary functions of the brain. Then comes to the most 2 important ones. One is actually the oculocephalic reflex, which is otherwise known as the Dolce reflex. And the second one is the oculovestibular reflex is actually there. That is the cold caloric test. So first coming to the Dolce movement, that is the oculocephalic reflex. What we usually testing is actually the cranial nerve number 3, cranial nerve number 4, and cranial nerve number 6. That is the oculomotor, trochlear, and also the abducent nerves. So that is actually the Dolce movement. So what we used to do is that we will immediately turn the brain. That is actually immediately turn the head 90 degree towards one side. So we know that as exactly like that of the name, that is a doll's eye. So once we turn it towards the opposite side, the eye should move towards the opposite side. That is a normal doll's eye present. And in case of an absent brainstem, or if the brainstem death has happened, there will not be any movement of the oculocephalic reflex is actually there. Now, the next most important test that we are actually doing is that, and one contraindication for the oculocephalic reflex is if there is a cervical spine instability or high cervical spine injury, it is contraindicated. In such cases, what we can do is the next test, that is a oculovestibular reflex, that is actually the cold caloric test. So here we are testing the 8th cranial nerve, that is the vestibulocochlear nerve. So what we usually do is that the normal response is instillation. First thing is patient will be in supine position. There are certain prerequisites. First thing is that we have to elevate the patient towards 30 degree from that of the supine position. Then instill 50 ml of a cold saline, ice cold water into in the ear for approximately 30 to 45 seconds. And we have to look for that of the eye movements. So what happens is that in the case of cold water, if we are instilling, the eye will move towards the same side. That is actually both eyes should move towards the same side. If we are actually doing with that of the warm water, then both eyes will move towards the opposite side of the instillation. This we have to do for both the ears also. And if there is no eye movement within 3 minutes of installation of this cold saline, then we can tell that the test is positive. That means the brainstem reflex is actually absent in the case of oculovestibular reflex. An important point to be noted here is that suppose if I am injecting cold saline in one ear and suppose if I'm injecting into my right ear, and if the only right side eye is actually moving towards the same side, while the left eye is actually remaining static, or it is actually not at all moving, then it is not considered as a brainstem death. It is a possibility where there could be either a brainstem lesion, or it could be seen in the case of intranuclear ophthalmoplegia. So that is actually the vestibulo-ocular reflex that we are actually doing. So totally we are actually doing 6 brainstem reflexes in order to label the patient as a brainstem death.
You nicely explained. Just explain regarding spinal reflexes also.
Yeah, spinal reflexes means that it includes all the reflexes that comes below the level of the medulla. So in the definition of the brainstem death, if we are actually explaining what is meant by the brain death, the brain death is actually irreversible loss of all the functions of the brain, including the cortical functions and also the brainstem functions, even though the patient may have an intact spinal reflex. This means that sometimes what happens is that the spinal arcs may remain intact. So what some of the example for this is that there will be a sign known as the Lazarus sign, or there will be startling responses will be there. So all these things are actually not a true reflex. These are the intact spinal reflexes. And there is something known as the abnormal Babinski or the triple flexion, where once we elicit the plantar sign, what usually happens is in the triple flexion is that there will be flexion at the hip joint, flexion at the knee joint, and also flexion at the ankle joint is actually there. That is a triple flexion. So one is Lazarus sign. Second thing is actually the startling phenomenon. Then third one is actually the triple flexion. Fourth one is undulating toe. So there will be just a movement of a toe will be actually there, which we actually see either during the eliciting any other particular test or while clinical examining. So these reflexes, if present, it will not rule out that the patient is not brain dead, because it can be also present or it is intact in the case of these patients also. That is a brain death patients also.
So this is very important because I have faced a lot of troubles and problems because I have managed nearly more than 45 cases of brain death cases. So we know spinal reflexes can lead into a lot of problems because patients admits at the time of counseling, we need to counsel them exactly to understand what is spinal reflexes.
Yes, sir.
Yeah, there are certain, just few questions before we move on. The questions is like this. See, with the pregnancy patient, any concern of apnea test if viable, fetus more than 23 weeks, what is the issue like, you know?
Yes, sir.
What is it? Raj K Mani.
With a pregnant patient, you have to be looking after the baby. It depends on of course the stage, and
yeah,
so
weeks.
there has to be firstly a multidisciplinary meeting whether you want to continue with the
issue comes
somatic
in
support.
Most of the times is there is a local mortality, morbidity, because maternal mortality comes in a very big way, and the collector will be the officer, and AMPH and the doctor will be called for any death of this one. So whether you call it a brain death and pregnant death, that is another important aspect. You need to make a compulsory gynecologist present, and you need to open and see if more than 24 weeks and less than 23 weeks, maybe that's considered as, because presently the rule is different from the abortion. So that has to be looked into the state-wise. And the thing is that what happens to the brain cells after the brain death, as you are telling about the pathophysiology, Dr. Cherian Roy.
Yes, sir. So that is what there is a rostral to caudal ischemia. So cerebral ischemia and also followed by infarction. So what happens is that there will be cell damage further leading to that of cell death and also apoptosis that will mainly take place. So suppose at the level of the cerebrum, if there is actually the blood loss is actually there, that will result in a vagal stimulation, which can cause in a decrease in the heart rate, decrease in the BP, decrease in the cardiac output also. If we move into the pons, what happens is that the infarction or the most important ischemia after the brain death, what happens is that here there is a combined effect of the vagal stimulation and also the sympathetic overactivity also. That is the reason why here we are actually seeing the so-called Cushing's reflex, that is a bradycardia with hypertension and chain stocks breathing or abnormal breathing pattern. Again, if we come down little bit down, that is towards the medulla oblongata, if we are actually seeing the ischemia and also infarction, here is actually what we are actually seeing as an autonomic stem. There will be extensive amount of a sympathetic stimulation will be there. So what happens is that there will be increase in heart rate, increase in cardiac output, increase in BP, increase in systemic vascular resistance. Once the most important thermoregulatory functions are actually controlled by the hypothalamus. When it is getting infarcted, there will be this hypothermia. All those temperature control mechanisms are completely being lost. Once the pituitary is actually being damaged, then what we are actually seeing is that neuroendocrine issues that are usually associated with that of the brain death, especially it is a posterior pituitary which is getting affected more than that of the anterior pituitary. And once we move again down below the medulla oblongata towards the spinal cord, there what happens is a complete deactivation of the sympathetic system will take place. So what here happened is exactly similar to that what happened in the cerebrum, that is decrease in heart rate, decrease in BP, and decrease in cardiac output also. And the net effect of all these things will be hemodynamic instability will be there, then pulmonary changes will be there, neuroendocrine issues will be there, electrolytic abnormalities will be there, and one most important thing is that the necrotic tissues, once it jumps into the circulation, it can produce release of the tissue plasminogen activator, and it can produce a feature exactly similar like that of the disseminated intravascular coagulation.
So main pathophysiology of a trauma patient is, if there is a trauma, there is a mass blood and there is a raised intracranial tension, and it will reduce the cerebral perfusion, and due to less perfusion, there is a more ischemic injury to the brain cell and more edema, and it leads to a vicious cycle, and all the organ one after one can be damaged by this vicious cycle.
But one thing is very clear. One does not, by global consensus, there is not a total absence of any somatic activity, or brain activity, because some neuroendocrinal function may persist.
Yes.
Or
yes.
Some somatic functions like growing of the nails or something may persist. So by global operational consensus, those things don't take away from the diagnosis of brain death as per the current consensus, right? Because there are many implications, there are many arguments, controversies. There are even theological arguments. There are absolutists who want every cell gone. But if we want the evidence of no cellular activity, that should extend also to cardiac death. Are we so sure about every myocardial cell having died after cardiac death? So that is why the global consensus is an operational one, not an absolute one.
Yes.
Normally,
in India, brainstem death, that means the brain death.
Yes.
Not required, all the part will be dead.
Exactly. That is the American definition.
Yes.
In contrast to the UK definition, which is what we have adopted. It's what we have adopted. Yeah.
Once the cessation of the blood stops, how much time will it take for a brain stem death happens or brain death occurs?
Usually the neural tissue can persist 4 minutes without any oxygenation. If there is a cessation of the blood flow, the brain tissue will die within 4 minutes.
The permanent happens between 4 to 20 minutes maximum.
Yes.
Yes.
Yeah, go ahead.
So, as the routine management, the normoglycemia was actually maintained by injection regular insulin at 1 unit per hour. And the steroids was also started at a dose of injection methylprednisolone 15 mg per kg. And injection triiodothyronine T3 was actually started at a 4 microgram bolus, followed by 3 microgram per hour of infusion.
So how long you can keep the organs?
Yes, sir. Pardon me.
How long after brain death you can protect the brain death management? How long you can do?
That depends upon the cold ischemia time. So for heart, it is actually 4 to that of 6 hours. For heart and for lungs only, it is 2 to 4 hours. For liver, it is actually 12 to 18 hours. And for kidney, it is actually 24 hours. And for bowel also, it is approximately 12 hours.
And bone also 48 hours. So maximum time is the 48 hours.
No, if the patient you are able to manage, you can continue because there is a criteria for the different organs donation. As long as you are maintaining them, not a problem. Because for example, what happens in the city, like for example, in my city, I don't have a heart transplant regularly and a liver transplant previously. Now everything we are doing. So at that time, we need to get because we want a maximum utilization of the organs to be utilized for the brain death. Because at least minimum 8 organs can be used. And it can go up to 12 organs, depends on it. So with that, we need to maintain properly, very closely, because it fights between the lung and kidney, because more fluid is dangerous to kidney, lung, and less fluid is dangerous to kidney, like that. And you have to maintain anyway, you are given the criteria of what organs to be perfused for what level and what is the criteria. You're doing tea, you're doing, everything, you will analyze the patient regularly and go ahead. So with that, we need to wait for the team to come and take the organ. So you need to really continuously monitor, balance, and to maximum utilization of the organs to be done. Because what happens is the nephrologist and neurologist will be fighting that I need to take the patient instead because my organ is more important. So if you consider me, I'm not the organ retriever. I'm the person who is going to manage the brain death patients. So that is why I will not give the consent till the maximum availability till the marker comes. So I continuously monitor it and do it. That is the most important aspect.
Yes. Maximum organs we need to try to harvest the patient.
Another problem comes is nowadays in India, for everything, even for a birth, they want a time of some muhurtam. The death also, they want a time of muhurtam. A good day, bad day, all these things comes. So the thing when the brain death comes, if death you declare, they will not have a problem. But when the brain death comes, attendants will be asking, when are you going to give us a body? So that timing management is a very, very crucial. So we really have to, should not give the time because it makes a problem later on. So yeah, because it depends on the entire organs, entire perfusion, what organs, donor availability, logistics, everything comes into that. So do not commit anything. If you commit, you have to give it.
Yes.
As they were asking about the organs, what are the 12, including the pancreas, and you look at the skin, and you look at the intestine, you look at the
bone, tendon.
Yeah, all these things can be given. Depends, because it gives more time also. That can be done, Satish. Yeah. Anything else, Dr. R K Mani, or a nice presentation, nice explanation, Dr. Cherian and Tapas Biswas, right? So very nice, and because the TOTA Act is very important, and recent, as you said, the amendments are important. Local, because health is a state issue, so you have to really go into the depth of it, and legal issue, because what happens is, as I said, when you are writing in the case sheet, documentation is the only thing which makes your life more safe, because even the patient gives consent, they only will answer at the end of the saying that because of the pressure and our mind that they have been asked, so we have signed. Always you writing on the case sheet saying that I have explained to so-and-so person consent are given by them has a more validity in the legal frame rather than you taking the consent form. Consent has a less value than you writing in the case sheet. That's one very valid point I really want to tell you.
You see, very important aspect I'm going to now touch upon. Now, supposing this patient and the family had not agreed for transplantation, then what do you do with this patient? What would you have done, Cherian, with Tapan?
Sir, can you repeat the question, sir? I didn't...
Supposing this patient had not, this family had not agreed for transplantation.
Yes,
okay?
Sir.
Not a potential donor, but brain dead. How would you proceed?
Yes, sir. Disconnect the ventilator and dispose the dead body.
Exactly. So that is the correct answer. Because the ICU, the management of the potential organ donor is only valid if there is an organ donation agreed upon. If not, brain death is equivalent to death. But yes, how many of you are now doing that? If it is because consent for transplantation is the minority. Majority are not agreeing, isn't it? Consent.
Attendants are not accepting, sir. Attendants will not accept.
No, that is what. See, there are two things. One is attendants not accepting. Another is the doctor not accepting. I'm asking whether the doctor is accepting or not.
The doctor accepting, sir. Only attendants are not accepting.
Right, very good. Thank God. Why is the doctor accepting?
Because he knows
what is the evidence basis?
No, because doctor knows patient brain death is death.
Yes, evidence of brain death. Evidence of brain death. Evidence of brain death being equal to death.
And it is
derived from what? Derived from what? See, in our law, this brain death is described only in the TOA. It is not described in the Registration of Birth and Deaths Act. Nor is there any other legislation which is defining brain death. This confusion is there in every physician's mind and neurologist's mind. There are very few neurologists who are writing brain death in the absence of a prospective donation. That is why Kerala government had to come with this law that every patient must undergo brain death testing, whether or not there is a potential organ donor. Are you aware of that? In 2020, Kerala government had to specify because otherwise they're carrying on brain dead people. This is extremely common in our country. So-called somatic, useless, brainless support. Right? This is what is happening because of the confusion created by the perception that brain death is defined only in the Organ Transplantation Act and not outside of it. So what? It's defined somewhere.
Yes.
And our TOA describes death as either brainstem death or in a cardiopulmonary sense. That is what the Article 2E says. So that is your evidence basis.
Yes.
Right? Death has been defined. And dead donor rule is a primary rule for cadaver transplantation anyway. So if the patient was not dead to begin with, you wouldn't proceed with a conversation about potential organ donation. So if the family agrees the patient is dead, if the family doesn't agree for transplantation, patient isn't dead. So that doesn't make any sense.
One more question.
So if we are convinced, then we are able to convey the conviction with the family. Because I always remove. I have never kept the somatic support continuing. Because the patients, apparently they have a problem in, they deny it initially, you have to persist and you have to project conviction within yourself. Otherwise you are unsure about the law. You think somebody might catch your neck and so you are wishy-washy, then this won't happen.
One more
another
thing.
Is, sir, another is ICU is a highly costly and unavailability bed. If I keep on unsalvageable patient, it will the waste of our national resource. So we have to disconnect the ventilator and dispose the dead body.
You see, in our country, if some third party is paying, we don't worry about resource misutilization. So who is the protector of the resource? It is the medical personnel, and therefore our counseling, our talking, our conveying, our standing for something is this. But what is happening is, in the majority, even in government hospitals, you can see that loads of patients are on brain dead patients are continuing on ventilator. And I have seen neurologists writing in the case notes, prognosis poor. Well, you got brain death. How can prognosis be poor? There's no prognosis. So these are misleading statements, and that is why we mislead the families as well in our counseling. Once you're dead, you're dead. There's no prognosis. So yes, these are the clarity we must bring in our practice. And then see, now there is a big drive, I'm part of it, to redefine death, right? The registration of Birth and Deaths Act is being revised to include brain death properly. Now the RBD says what? So there's no evidence of any activity of life, permanent cessation of all activity of life. That's all it says. Okay. After the birth, anytime after birth. So this is 1969 Act. Now, if we have to add another thing, permanent cessation of all activities of the brain, whether by a circulatory reason or by a direct brain injury reason. So this has been added and is submitted to the government. And now in a month's time, we should have a redefinition. Right. Then this ambiguity should go permanently from our brain. And so what does are you aware of a big document called the Brain Death Project? So there is a document which you must read, the World Brain Death Project, right? So this was 2020 JAMA document. So all the countries together, they have made a consensus. They have said continuation of the somatic support after brain death is only in 3 circumstances, all right? In the circumstance of potential organ donation. Number 2, I mentioned, if there is a pregnancy and there is a possibility of a viable continuation of pregnancy, and that too after all consideration, multidisciplinary meeting and family meeting. And number 3, if there are religious and moral considerations due to which the family objects. But in that case, in the 3rd case, you give 48 hours time for reconciliation and counseling. It's not forever. So this is the World Brain Death Project recommendation, and you can use that for advocacy within our own country so that we bring about clarity. Because it is morally, medically, and also from utilization of resources perspective, it's not at all correct to continue with so-called somatic support.
All the points of 3 points of advocacy is very, very important and crucial, Dr. R. K. Mani, sir. And one just small question, what has actually happened and dilemma yesterday itself. I had one patient who has been previously renal transplanted, presently brain death. Who has to give consent for that? That was a question.
Sorry? Who? Okay.
Post-transplant.
You said what?
Post-renal transplant patient.
Oh, died. Had brain death.
Brain death. So who has to give consent?
I mean, the same way as a non-transplanted patient.
I understand.
Yeah,
because that was
the same way.
because it belongs to somebody else.
No. See, it belonged to somebody before, but once it's transplanted and then it's part of the internalization of the body, it becomes part of the body. You know, this is also an ethical controversy which has been discussed.
Yeah.
See, for example, you have an LVAD.
All this for everybody's knowledge.
LVAD is a device which is supporting you like a ventilator from outside. Okay, LVAD has been inserted inside, or ICD has been inserted into the heart. So, but that is not a part of the system, of the organic system. Okay, so that can be stopped, removed. But you can't remove a transplanted organ because it becomes a part of you. See what I mean? So there are ethical questions which have been addressed by others.
Just to make a clarity of dilemmas.
Absolutely.
Any other questions? I think Dr. Misra, you can take over.
Thank you very much, sir. I think it was a wonderful session. There is no doubt, even I think not only the students, a lot of other people, I think few people, international people also, I think they are the students from Singapore and few of the African countries also joined today's program. I think it must have been benefited like each and every person, including me. It was nice to hear like the wisdoms of Mani sir and Mohan Maharaj sir. Actually, they are the...
Dr. Misra, one final point I want to make.
Please, sir.
Somebody had asked in the chat box whether DCD, that is donation after circulatory determination of death, is possible in India.
Yeah, you answered.
And Mohan Maharaj has written not in India. I have also written not in India. But I must tell you, there are efforts on to include this protocol into the TOA. And I happen to be a part of the task force. So we have submitted a white paper. It has been published in the Indian Journal of Organ Transplantation and Indian Journal of Critical Care Medicine, a consensus document on what a DCDD protocol would be. And this has been submitted to the government. The government is on this job. You know, how a DCDD can happen is only if withdrawal of life support is possible. Okay. Now, our last Supreme Court judgment in January 23 has made that very, very amply possible. We can do WLST, withdrawal of life support. So that is a crucial step. Then you can look at the document, see how from WLST you can get a controlled DCDD, which will improve the organ pool for us, available organ pool. In many countries, that has outstripped the DBD availability of organs. For example, the Netherlands. So this is just as a passing shot, right? So please look at the possibility of DCDD, which is on the horizon. The Ministry of Health is looking at it. Maybe
Shanbag case, sir. Puruna Shanbag case, Supreme Court order, there is a withdrawing of life support. 2000.
You know, Aruna Shanbag case said that from vegetative state, you can remove support. That was, she had only the nutritional support.
Yes, sir.
However, the next of kin, in her case, it was the next friend, all the nurses group, they didn't agree. But they had a big procedure through the court and everything, High Court.
Yes, sir.
But we have evolved, our laws have evolved. Then there was Common Cause Judgment of 2018.
Yes, sir. Indian Law Commission, Indian Law Commission also recommended for the withdrawing of the life support, but it is the under process of the law.
Yes, so that is now validated. The procedure is simplified. So the latest is 2023 January amendment of the Common Cause Judgment, where you can take a withdrawal of life support decision. It is not just for vegetative state. It is for any case where it is futile. We have got the IDCCM guidelines on all those situations. So end of life care has come to intersect this organ transplantation. So that's how DCDD has become a possibility. And so even you don't have to be brain dead, but you can be neurologically irretrievable, right? You don't have to be brain dead. You can be neurologically irretrievable, and then a decision for withdrawal of life support can be taken on the basis of futility. And then also the person can be a potential organ donor. Sometimes as you are doing brain death determination, in the process, cardiac arrest takes place, right? So you need not do a CPR, but you can take the patient as a DCD, as an organ donor. So all these are possible.
Yes.
So we are on the threshold of improving reform in this area, which will improve your practice, right? And improve the organ pool.
Yes.
So thank you very much, sir.
We had a great discussion. I'm very grateful for this session.
Really great discussion, sir. And I should thank Dr. Cherian and Dr. Tapan at bringing up the case, and the way they answered the questions were really commendable.
Superb students.
Really appreciate
Congratulations, dear students.
Thank you, sir. Thank you.
And I should thank each and every person who has attended the session today. And thank you all, sir. And good evening and good night. We'll close the session here. Thank you.
Yes, good night.
Okay, sir.
Thank you.
Thank you, sir.